بس أسأل سؤال يعني كانت القاعة مليانة بالمحاضرة الأولى، المحاضرة الثانية نزلت، المحاضرة الثالثة رجع العدد يعني ارتفع. شو المشكلة؟ وين كانوا؟
ماخدين بريك. بريك.
ما شاء الله. على كل هو اللي يحضر هو يستفاد براحته. ماشي. So we are still in the pathway of the nervous system. We start with the central nervous system and we go now to the peripheral nervous system. And from the first lecture, we said that the peripheral nervous system starts from the anterior bone cell and distal. The root, nerves, neuromuscular junctions, and muscle. And there are general concepts, general features of the peripheral nervous system. Now, the peripheral nervous system, of course, it is a disease of a lower motor neuron system. And so the lower motor neuron is involved, starting in the anterior horn cells, and also the cranial nerve. Now, the symptoms of the different problems and diseases of the peripheral nerve, usually they share common symptoms and they differ in other symptoms. They share common symptoms because the lower motor neuron, but there might be difference. Depends, of course, on the area involved and the disease process, as we will see later on. And these symptoms could be motor symptoms, sensory symptoms, and so on. Now, because it's a lower motor neuron, from the first lecture, we said that the characters is the hyperplexia, atrophy, fasciculation, flaccidity, and so on. Now, by the way, not every peripheral nervous system disorder have all the symptoms. It depends on the site and the disease process. So it depends on the disease process and the distribution. Okay. So we will start on anatomical characters. As we said, we have the anterior horn cells, then we have the root. And the root, by the other name for the root, is the radical. And that's why root problem, nerve root problem called radiculopathy. We'll talk about this later on. And different roots join together to form plexus. This is from your anatomy. And the problem with the plexus is plexopathy. Also we'll talk about it. And the plexus will be divided into single nerves, peripheral nerves. And the peripheral nerve could be affected either a single nerve, and that's called mononeuropathy, we'll take example for that, or multiple nerves at the same area, and this is called polyneuropathy. Or multiple nerves, but it is patchy, not in the same area. And this is called mononeuropathy multiplex. Now we'll discuss each one. Now we start with the radiculopathy. Now, the radiculopathy, the radicals or roots, the involvement could be the cervical root higher up in the neck or in the lumbosacral roots, lower down. Now, the clinical presentation usually of root problem, which is a common presentation, most of you they know, the patient will be presented with pain. And that pain called radicular pain. Why we call it radicular pain? Because it starts, for example, at the cervical area, start at the neck and radiate down in the upper extremity. That's called radicular. It radiates. And this is cervical radiculopathy or brachyalgia. Or start in the lower back and radiate down to the lower extremities. And this is lumbosacral. Common things, you know, it's sciatica. So pain. That pain, sometimes severe. It depends on the degree of the root involvement. Degree of root disease. Sometimes mild, sometimes moderate, but sometimes it's very, very severe pain. And usually, the sensory symptoms related to the involved distribution. That's the sensory symptoms, pain. Sometimes the pain is so severe, prevent the patient from sleeping, or the patient cannot walk properly. Pain at the back, and getting down to the leg, either right or left. Or sometimes pain in the neck, radiating to the upper limbs. This is early on. If missed and not diagnosed, then we'll have complication. Then motor symptoms will develop. So motor symptom is advanced. We start with sensory symptoms, pain. But if not treated, then we'll have motor symptoms. And the motor symptom characterized by weakness, or sometimes in an advanced case, atrophy of the muscle which is supplied by that foot, which is a very late symptom. Now, what are the causes of the root problem, radiculopathy? We divide it into two categories. One is called the compressive, compression, and the other one is called non-compressive. Common things for the compressive, most of you know, is a disc problem, discopathy, disc, most common. And usually, the intervertebral disc, because of tear, because of heaviness, lifting heavy weight, exertion, that leads to rupture of the disc and herniation. And that herniation will go outside the vertebral body and will press on the root. And depend on the degree of herniation and the severity of the compression that is presented with just symptoms, pain, mild, moderate, severe, or sometimes pain and complication, if not diagnosed, like weakness or atrophy. The non-compressive, like systemic disease, diabetes, or infection like herpes zoster. Now, how we diagnose? We diagnose clinical diagnosis. By history of this. History. The patient gives you typical history of either pain and different categories of pain, or weakness, or numbness, or whatever that. And also, by certain examination, by the straight leg raising test. Patient lie flat, then you flex the hip and an extended leg, then you'll have pain. Now, we need investigation. We need MRI in the involved area to decide the level at which disc level is involved. Because the disc level could be herniation between the lumbar area and the lumbar area, 5 areas, sacral area, or cervical, at which level of cervical area. So we need MRI for diagnostic purposes and for further management if you think of surgical intervention. Also, we do physiological tests like the EMG or nerve conductions to decide the degree of conductivity in that route. And also the EMG will decide the effect of the radiculopathy on the muscle itself. Now, the treatment, number one, it's according to the etiology. Number two, it depends on the severity. For example, if it's very mild, sometimes we use conservative treatment. Conservative treatment by spinal support, هذا الحزام الطبي كلكم تعرفوه, lying and complete bed rest, lying, sleeping on a rigid bed with a painkiller. But sometimes conservative measures is not effective, that interfere with the function of the patient, or complication, presence of complication, that force us to ask the help of a surgeon for decompression of that disc to relieve the pressure on that route. So it depends on the etiology and the severity. That's for radical or radiculopathy. So that's MRI, okay? And these are vertebral body, and these are the discs. Herniation of this, herniation of this. Goes out and press on the root. Look, pressing on the root. So MRI is very important in localization. أحدكم يا ديتيل النيوروسيرجن، النيوروسيرجن يهتمون كثير بالليفل. They ask you about the level كثير. راح أحكي فيها. Okay. What about the plexus? The same thing. Plexopathy, like radiculopathy. Same thing could affect the neck, brachial plexus, or the lumbosacral down plexus. And the presentation, the symptoms and signs, is the signs of a lower motor neuron disease. And the distribution of that plexus. And it's like the radiculopathy, presented with symptoms like pain, but later on with complications like numbness and weakness and atrophy. And also the causes like radiculopathy, compressive and non-compressive. But here, the compressive and the plexopathy differs from the compressive of radiculopathy. Why? Because the compressive causes, the plexus, cervical plexus, usually it is nearby the upper or apex of the chest. So any problem, for example, in the lung, that lead to, for example, tumors could invade that brachial plexus, or sometimes secondary from breast. That could involve the brachial plexus. The same thing about the lumbosacral. Any problem in the pelvis, like for example, gynecological or colorectal problem, like tumors, also could involve the lumbosacral plexus. So the compressive course, it is more serious in plexopathy more than in radiculopathy. But sometimes the compressive could be by benign cause, like abscess or aneurysm, or sometimes hematoma, especially due to trauma, pelvic injury. The non-compressive cause, like radiculopathy, we have diabetes, infection, and we have entity called radiation-induced plexopathy. What we mean by this radiation-induced? Because those patients who have certain diseases in the lung or the breast, like tumors, they need a protocol of treatment. And one of the protocol of treatment is radiation. And that radiation, per se, by itself, could affect the plexus and cause radiation plexopathy. How we diagnose it clinically? And we do the MRI, and we do the EMG and nerve contractions, and the treatment according to the pathology. This is the plexus, and this is the flame plexus. Flame plexus. Plexopathy. Okay. Now, from the plexus, we have different nerves. And we could have a single nerve involvement, and that lead to a sign and symptom depending on which nerve. The most common cause in the upper extremities, we have the median nerve, carpal tunnel syndrome, the ulnar nerve or the radial nerve. And in the lower limb, we have the peroneal nerve. We go to the carpal tunnel syndrome or median nerve. The median nerve. Usually the median nerve is compressed at the wrist. Why? From the name carpal tunnel. Because the median nerve, to pass from the forearm to go to the palm, it passes into a tunnel. And while passing in that tunnel, it could be compressed, called carpal tunnel syndrome. And there are certain risk factors for that. For example, patients with thyroid disease and fluid retention, or patients with rheumatoid arthritis, or pregnancy. Some of the ladies, they are all right when they get pregnant because of the edema of pregnancy, they get carpal tunnel. And that carpal tunnel could resolve after pregnancy or sometimes persist. Systemic diseases like diabetes or sometimes occupation, those working with vibrating tools. Now the symptoms, initially sensory symptoms, characterized by palmar pain, pain in the palm. But sometimes the pain not restricted in the palm, but ascend up in the forearm or even up to the shoulder. The pain could be very severe, especially at night, waking the patient from sleep. And the patient wake up and try to shake his hand to relieve from pain. Also, that pain associated later with sensory symptoms. like numbness and tingling sensation. And the numbness and tingling sensation, usually it is at the fingers, which is supplied by the median nerve. And that is the lateral 3.5 fingers. Lateral 3.5 fingers. Later on, misdiagnosed, later presentation, weakness will develop. And the weakness will be in the muscles supplied by the median nerve. But in advanced cases, there will be wasting and atrophy. The thinner muscle wasted, become depression. Wasted. Too late. Now, also, on examination of patients with carpal tunnel syndrome, if the patient extends his wrist and you percuss the wrist, they are feeling of numbness. This is the tunnel signs. Tunnel signs. Of course, diagnosis clinical from the history and doing the EMG and nerve conduction. The nerve conduction here is very important. Number one is diagnostic, because you measure the velocity of sensory velocity in the median nerve between 2 points. You stimulate, we have electrode to stimulate and electrode to receive the sensation. And you calculate the time for travel. We have normal time, but when we have carpal tunnel, there is delay, so the time is prolonged. This is diagnostic. A prognostic, it also categorizes the type of the carpal tunnel, whether it's mild, moderate, or severe. Depends on the degree of the blockage and delay in the conductivity and the median nerve. So this is very important for the nerve conduction study. Also the EMG, because you study the muscles which are supplied by the median nerve. Now treatment, we divided the conservative and surgical decompression. Early on, conservative, mild symptoms, especially in pregnancy, we give a wrist support. A wrist support. Like ذول اللي يلعبون تنس يعني, wrist support and some painkiller. That's good. But if the problem is very severe, that prevent the patient from living normally, then we ask the surgeon for decompression at the tunnels. Decompression, remove the fibers around the nerve. So this is the carpal tunnel syndrome. That's the median nerve. About the second nerve is the ulnar nerve. And usually the ulnar nerve compresses not at the wrist, but at the elbow. Usually at the ulnar groove, behind the medial epicondyle. And the symptoms usually sensory symptoms, but the sensory symptoms, the numbness, tingling, it is at the medial 1.5 fingers, medial. And sometimes, advanced case, we have motor symptoms, like atrophy in the muscle supplied by the ulnar nerve. Of course, diagnosis, you use nerve conduction, EMG. And the treatment, same thing, early conservative, late surgical. Thirdly is the radial nerve. And the radial nerve, usually, there is compression of the radial nerve in the spiral groove of the humerus. This is called Saturday night pulsing. عندنا صورة كيف ال
هذا بكون قاعد على الكرسي.
مم.
نام على الكرسي هيك.
مم. اوكي. Radial nerve problem. And usually the symptoms are motor more than sensory. For example, Saturday night, the patient on the edge of the chair, puts his thumb on the edge of the chair and sleeps. And there is pressure, sleep. And there will be weakness of the muscle, the dorsiflexors, and that lead to a wrist drop. يعني هو جالس على كرسي نايم and then pressure, and that will be wrist drop. And the diagnosis clinical, of course, plus EMG and nerve contact. And the treatment usually is a self-limiting, ما في مشكلة, with improvement within 8 weeks, 2 months. Physiotherapy, of course. Now, if the compression is caused by a mass lesion, you have to excise the mass. Wrist drop. Okay. The peroneal nerve, the lower limb, usually the peroneal nerve, where it's compressed at the fibular head, behind the knee joint. And the symptom usually motor rather than sensory. There is motor weakness of the dorsiflexors of the foot. So there is foot drop. And sometimes sensory changes in the peroneal nerve distribution. There are certain predisposing factors. For example, the sudden severe loss, دول يعملون sudden severe weight loss, يعملون عمليات تنحيف, sudden weight loss, sudden loss of the weight, or frequent leg crossing. في ناس تتعدى دائما leg crossing. Okay, especially in thin people, but sometimes could be caused by a mass lesion tumor. The diagnosis, of course, clinical plus EMG and nerve conduction study. What if the mass is suspected? Surgery. Usual treatment is self-limiting and recovery with physiotherapy. This is the okay. So this is a single nerve. Single nerve both. If more than one nerve is involved, polyneuropathy. And the polyneuropathy, the classical chronic polyneuropathy, or sometimes called peripheral neuropathy, means multiple nerves but at the same area. And of course, that is length dependent. كل ما يكون النيرف طويل ومعرض للبولينيوروباثي. يا شباب خروج للمحاضرة أثناء المحاضرة أول شيء disturbing للمحاضرة، وإذا أنت ما بدك تدخل المحاضرة خلاص من أول كان ما تيجي، مو علشان أعمل غياب وطرد. فبعدين حضور المحاضرة هي فائدة لكم، لأن في شغلات نحكيها ما مكتوبة فينا، وأسئلة تنسأل بالأورال وتنسأل بالرتن أو تيجي على شكل بالامتحان من يوسكت تيجي على شكل كيس هيستوري ما مذكورة، بس احكيها أنا مطلوبة. اللي ما يحضر هو يعني هو it's up to him، بس اللي ما يحضر من أول ما يحضر، بس أثناء المحاضرة غير يعني ما أقدر أقول لك كلمة بس مو صحيح. anyway يعني disturbing حقيقة. أنا أقدر أقول ممنوع الخروج خلاص، بس أنتم ما شاء الله عليكم يعني واصلين مرحلة مشهور هنا، مو مسألة منع وشغلات أنا طريقتي إنه اللي بده يحضر يحضر، ما يستفاد لا يستفاد، بس لا يأثر على المحاضرة، لأن يعمل يعني انتربشن حتى للأفكار اللي بنتكلم عليها، اللي بنتكلم بالمحاضرة هذه بتأثر. So, the chronic polyneuropathy, as we said, it is length dependent. And the symptoms and signs start distally and progress proximally. And usually it is bilateral, not unilateral. مهمة جدا. And the symptoms usually sensory to start with, and then sensory and motor. And the patient, they usually start with the sensory symptoms, especially those patients who have risk factors, like diabetes. They gave history of pain at the feet, burning pain. الدكتور ما بقدر انام بالليل، كأنه جمر at the sole of the feet. Burning pain. بحرك الجلد دائما. Restless foot, restless leg. Severe, especially at night. So the pain is unbearable. ما يتحمله واحد. And of course it's bilateral, burning. And in advanced case, could be associated with weakness in the peripheral muscles or even worsening of the interossei muscle. Now there are certain predisposing factors like diabetes, very common, but certain organ failure like hepatic failure or renal failure, thyroid disease, or autoimmune process. They found that certain medication like chemotherapy, complication leading to polyneuropathy, or certain toxin and alcohol. It's very common, alcoholic polyneuropathy. Wow. Nutritional, vitamin deficiency, especially vitamin B12 or folate. Or sometimes hereditary one, by hereditary called the Charcot-Marie-Tooth. And the diagnosis called clinical plus nerve conduction and EH. Now treatment, of course, according to the etiology, to treat the etiology, but we have a problem of neuropathic pain, the burning pain. Those who got neuropathic pain, they don't respond to the usual analgesic drugs. Sometimes we use modifying drugs. Sometimes we use anticonvulsant drugs, like Tigritol. And the value of that is to take the age or sharpness of the pain. ما يروح البين نهائيا بس يقلل من حدته. Take the sharp end of the pain. And that's the neuropathic pain. Okay. هنا موضوع جدا مهم. خلصنا بالكرونيك. Now this is the acute. Acute inflammatory demyelinating polyradiculoneuropathy. AIDP, or Guillain-Barré syndrome. It's a medical emergency. Medical emergency, very important. Usually, the patient have history of infection, like upper respiratory tract infection or GI infection. Some time ago, a week, 10 days, and probably that infection will trigger the autoimmune reactions and causing this acute neuropathy. So the patient can give history of progressive weakness. Weakness زايد مع الوقت over the last 2 weeks, and start in the lower limbs, then ascend up to the upper limbs, and usually peak about in 2 weeks' time. And by definition, it's less than a month. And that weakness, because the lower motor neuron associated with the reduced or absent reflexes. Sometimes the weakness could involve the cranial nerve or respiratory muscle. And this is very critical and dangerous condition. That's why if you suspect carpal tunnel syndrome, you treat the patient in the intensive care unit, not usual ward. Why? You admit him to the ICU to follow up the respiratory status by doing frequent pulmonary function test. Not waiting to the APG. ما تستنى إلى أن الأكسجين بينزل بالدم. It's too late. You do frequent، تخلي جهاز بيك فلوميتر أمام المريض كل ساعتين بينفخ وتشوف إذا كان respiratory function is reduced. هنا it is alarming. Immediately you call the anesthetic to come, because this patient might need assisted respiration by endotracheal tube and respirator. You don't wait until hypoxia happens. When hypoxia happens, it is too late. وعندنا experience كثيرة إنه المريض يدخلوه ما يدخلوه بالآي سي يو، يدخلوه medical ward. يجي الدكتور الطبيب الصبح، he found that the patient is dead in his bed. They thought he was sleeping. No, he was dead. Happened. Young patient in his 20s, admitted to the ordinary ward. نام دنيا شتاء، خلى البطانية على راسه، الصبح صح وما بيصحى. Death during sleep. So that patient should be treated in intensive care with a frequent respiratory function test. Don't wait for the APG. And of course, the diagnosis is a clinical plus the EMG nerve conduction and CSF examination. Now صار CSF examination because it showed a raise in the protein of the CSF. Raise, so it's a medical emergency. كثير يجي case history بالمينيوسكي. patient هيك عنده history هيك دخل هيك صار. طبعا the differential diagnosis is a transverse myelitis. هذا راح نتكلم عليها. هو inflammation at the spinal cord هنتكلم عليه بعدين. طبعا التريتمنت هو usually immediately plasma exchange or IVIG. IVIG متوفر وبلازما exchange. الترانسفيرس مالايتس اللي هو could be called inflammation of the spinal cord at a certain level, could be by many causes like idiopathic one or inflammation or systemic inflammation or autoimmune or sometimes multiple sclerosis. So this is the spinal cord, and part of the spinal cord is inflamed, dead. And usually the symptoms, there are several different group of symptoms of transverse myelitis. Some of them they present with abnormal sensation, pain sensation, bladder problem, or muscle weakness. But the most important, there is sensory level. Sensory level, for example, up to T10, T9. هذا ما يصير بالجوليوم بري. جوليوم بري diffuse peripheral nerve. لكن transverse myelitis it is. ولهذا the most important differential point is between Guillain-Barré and transverse myelitis. وكل واحد له مانجمنت خاص.
دكتور ايش بصير بالسنسوري؟
نعم.
ايش بصير بالسنسوري؟ ايش بصير بالسنسوري؟
ما هو يكون هذا الليفل نوع يكون loss of sensation up to 9 T9 بعدين يرجع طبيعي sensation. معناه عندك ليفل واضح. انا اكو spinal cord كانه مضروب في المكان هذا يفرق لك، بينما بالجوليان-باري لا فرق. ومثل ما حكينا انه التريتمنت هو لازم اكسشينج مثل اي بي اي جي. اوكي this is acute. اكو عندنا chronic inflammatory demyelinating polyradicular neuropathy CIDP. يختلف عن ال AIDP. It is similar to the AIDP, لكن the progression of symptoms is longer, more than 8 weeks. شهرين. هذاك maximum 2 weeks. And the symptoms are motor and sensory symptoms. طبعا with the reduced reflexes. The presentation, the chronic, has two types of presentation. أما monophasic يصير weakness مستمر or relapsing pattern بيجي ويروح up to 2 months. And the diagnosis, of course, same thing, clinical, EMG and nerve conduction. هون طبعا treatment IVIG لكن steroid is indicated. بينما بالجوليان-باري there is no role for steroid. وهاي الطلاب لازم نفرقوها. كثير بالاورال يغلطوا فيه. ستيرويد بالكرونيك CIDP مو بالAIDP. IVIG بالاثنين يستعملوا. وسمتايم لا تستعمل كرونيك ستيرويد، بعض الاحيان تستعمل ستيرويد سبيرنج ايجنت. ستيرويد سبيرنج ايجنت. اوكي. Finally, we have what we call the mononeuropathy, multiple nerve at multiple areas. So more than one nerve is involved, but not one near to the other continuous. So it's a patchy one. And so there are different nerves involved at different time, at different areas. And this is associated clearly with systemic disease, like vasculitis. Because vasculitis could affect any nerve anywhere. Right upper limb, left upper limb, lower limbs, and so on. Vasculitis is the most common. And of course, diabetes. Okay. And the symptoms is sensory and motor. And the pain, the neuropathic pain, very, very severe. And the treatment will treat the etiology and treat the neuropathic pain. So, conclusion, you have to be very aware of the different type of peripheral nervous system disease, like mononeuropathy, radiculopathy, or plexopathy. And also you have to differentiate between, for example, mononeuropathy and radiculopathy. For example, to differentiate between mononeuropathy and plexopathy or radiculopathy, for example, perennial neuropathy, which is nerve, and L5 radiculopathy, difference. Carpal tunnel syndrome and radiculopathy C6, 7, 8. Radial neuropathy and cervical radiculopathy C6 and 7. Ulnar neuropathy and cervical C8.
كيف الفرق بينهم دكتور؟
الفرق بيناتهم لأنه النير يكون sign related to that specific nerve. Specific nerve, specific muscle. أما الراديكولوباثي لا، السيمبتومز تختلف والمسل involved أيضا يختلف. اوكي سو هذا يجيبنا الى نهايه، وصلنا تقريبا الى البريفرال نيرف. بس حتى ننهي البريفرال نيرف سيستم باقي لنا شو؟ باقي لنا البريفرال نيرف بيجي على المصل، يوصل للمصل and there is a neuromuscular junction and there is the muscle itself. In a neuromuscular junction it's a common problem. وكلكم تعرفون ال common problem like myasthenia. So the myasthenia is short note عليها. The myasthenia usually characterized by it's a disorder of the neuromuscular junction, and it is autoimmune disease, and it is autoimmune destruction and disruption of the nicotinic post-synaptic receptor of acetylcholine. شوف هون راح تشوف هذا البريفرال نيرف، هاي المصل، وهذا النيوروماسكولار جنكشن، هذا النيوروماسكولار. الاكشن بوتنشال سيجنال يجي بالنيرف، من يجي بالنيرف شو يصير؟ راح يصير انه يعمل calcium will enter inside the nerve terminal, and that calcium will lead to the release of acetylcholine. Acetylcholine will be released, and that acetylcholine will go to the neuromuscular area, and here we have receptors receive the acetylcholine and make a contraction. This is the normal. شباب، لكن بالمايستينا جريفيس اللي يصير انه الريسبتورز ار ديسترويد، autoimmune destruction، ما عندنا اسيتايلكولين باهي، والريسبتورز ايضا قليله، يصير reduction of the function of the acetylcholine، يصير weakness. So we have number one, the action potential go to the presynaptic terminal horn. Calcium will inside, then vesicle will release acetylcholine. Well, acetylcholine will go and bind itself to the postsynaptic receptor horn and muscle contraction. اللي يصير بالمايستينا جريفيس في antibodies will bind to the receptors فما تخليها تشتغل. So it will bind to the receptor side and causing destruction. It is a complement-mediated immune reaction. So these antibodies are referred as acetylcholine receptor antibody. Acetylcholine receptor antibody. How can be demonstrated by radioimmune assay and the serum, 90% positive, one of the diagnoses of myasthenia gravis. Now, in the human myasthenia gravis, we have reduced in the acetylcholine receptors site, I demonstrated in the postsynaptic fold, and the reduced receptor synthesis, أيضا, will increase the receptor destruction. So there's a blockage of the acetylcholine receptors to the acetylcholine, and that problem. We have clinical presentation. We have sometimes both the eye, ocular type, 20% eye, or sometimes mild generalized, moderate generalized, severe generalized, or myasthenic crisis. Myasthenic crisis هي emergency. طبعا الإفكت could affect the ocular muscle, lead to diplopia, or ptosis, or ophthalmoplegia. Respiratory muscle weakness lead to breathlessness or respiratory failure. Bulbar sphincter artery, limb and the neck, drop head and weakness. هنا هذا one of the signs. You ask the patient to look forward, then look up. Then you wait for 20 seconds to find that the lid will go down. The lid will go down. Vertical ptosis. The lid ptosis. This is a good sign of myasthenia. طبعا التست بيسموه تيست التنسلون تيست او الدروفونيوم تيست تنطي انتي كولين استريز حتى توقف شغل الانتي بوديز. انتي كولين استريز شورت اكتنج تشتغل انتي كولين استريز حتى يخلي زيد الكولين. اوكي given IV طبعا and dose of 2 to start 2 milligram slowly. طبعا والاتروبين خاف يصير يعني سايد افكت وتشوف اني امبروفمنت. فهنا تنطي فاذا كان امبروفمنت معناها مايستين، اذا كان ماكو نوت مايستين. وطبعا تبدي سمول دوز 2 ملي جرام وتشيك اذا اوكي كمل بال 8 ملي جرام في 10 ملي. هذا الدروفونيوم تيست. هذا البيشنت كان اذا مايستين تشوف دوسز تنطيه اكثر الدروفونيوم تيست تشوف يضحك the eyes are open. Other investigation هو EMG. نشوف هاي normal EMG بينما المايستينيا could be good contraction, gradually this will be reduced. The treatment طبعا in myasthenia crisis if the patient having respiratory failure طبعا immediately you admit to the ICU and you do ventilation. There are certain anticholine esterase drugs that will inhibit the choline esterase. Okay, so these inhibit the choline esterase, the enzyme responsible for the breaking down of acetylcholine. يصير عندنا كثير acetylcholine. وأيضا عندنا oral هو paradigmatic فقط للعلم. هذا هو النيوروماسكولار. وبعدين عندنا المايوباثي هو مصل ما راح اعطيكم اياه بس نشوف المايوباثي هو genetic problem by weakness of the muscle genetic. Okay, by this we conclude the cerebral nervous system. Okay, شكرا.